So we've got about an hour's time. So first of all, I'd like to welcome everyone in cyberspace. We are in San Francisco at Interventional Endoscopy Services. It's our department here at California Pacific Medical Center. And we have a very unique operation or center here that is dedicated exclusively to advanced endoscopic procedures. So the only type of cases we do here are referrals from other gastrointestinal specialists, whether gastroenterologists or surgeons. So it's a tertiary quaternary referral center. And I founded this center, what we call IES, in 2001. So it's we'll be celebrating our 20th anniversary pretty soon. At any rate, what we're also wanting to celebrate with this inaugural webinar, this is actually our first one, so we ask that you have some patience with us tonight. But we plan to do a series of these, as I don't expect that that COVID will be ending anytime soon. So this is definitely a good opportunity to get started with this platform. So we've chosen as our first topic the endotherapy of GERD, and this is something that a topic that I've been courting basically since I came to CPMC in 2001. And around that time, 3 modalities had emerged almost simultaneously for the treatment of GERD, endoscopic treatment of GERD. And it was at that time really quite revolutionary because our role as gastroenterologists, at least, was purely diagnostic, diagnosing GERD. And so we didn't play any role in treating GERD. But we had 3 modalities suddenly appear, and the first was RFA with the Stretta device, and the second was plication using the endocinch at that time. So both of those have fallen by the wayside, although I think Stretta has reemerged now, so it's been revived. And the third was the enterics procedure, where an injection was made of Onyx, a solution enterics, into the muscularis propria, the lower esophageal sphincter. Now, all 3 modalities actually showed very encouraging results, but they were all before their time. And the reason is because PPIs had emerged as well, and they were a godsend for our patients. And it certainly was difficult convincing a patient to consider, even though less invasive than surgery, but nonetheless, endoscopic therapy for a GERD. Most patients were just very happy on their PPI. So this was really before its time. Endotherapy was competing with PPIs, and the burden of proof was upon us to really prove that endotherapy could have equivalent outcomes to PPIs, including patient satisfaction. So the scene has changed completely now because, as everyone knows in the audience, it's our patients that are coming to us, and they're to us and asking, you know, I've been reading about all these side effects and red flag warnings from the FDA about side effects of PPIs. Need I be concerned? And what are my options, other options for treating GERD? So I thought this would be a very timely webinar because finally we're getting the type of data that we need to get dissemination in terms of insurance approval, coverage for this procedure. It's moving very rapidly forward, and experience dissemination is increasing. And one individual who has been able to get a great deal of experience under his belt is Andrew Nett. And we recruited Andrew Nett into our group in 2016. And we assigned to him as the director of advanced foregut endoscopy to really build this program for endotherapy of GERD, among other things, of course, but a big focus on that, because I think we're going to see just a phenomenal future here, and we're going to see many additional modalities come onto the scene. So without further ado now, I'd like to introduce Dr. Nett, and he also has an appointment at UCSF where he trained, did his residency, and he did his medical school training at an institution that I'm well familiar with, Baylor College of Medicine, because I did my residency there, and he did his medical school training there, and he did his fellowship training at the University of Michigan under Grace Elta, who I know very well and have known quite long. Also, James Scheinman, who left University of Michigan, I think a couple years ago, and he's at UVA now. So, Andrew, welcome, and we look forward to your talk, Endoscopic Therapy for GERD, Current Status and Applications of Transoral Incisionless Fundoplasty.
Thank you, Dr. Binmoeller. Hello, everyone. Andrew Nett here at IES at CPMC, for those that I haven't met. Thank you for joining us virtually this evening. Tonight, basically, I want to focus on endoscopic therapy for GERD, and the main sort of modality that's offered and that has the best evidence currently is specifically a procedure called transoral incisionless fundoplasty. So as Dr. Binmoeller mentioned, we hope to make this as first of a series of different webinar broadcasts, but bear with us if there are any technical difficulties. And then throughout the presentation, if you have questions that you think of that you'd like to ask, just go ahead and use the Q&A feature on Zoom. You can type something in, and then we'll go through questions in the remaining 15 minutes after the presentation. So without further ado, I'll start by mentioning basically that much of this talk will actually involve specific discussion of a device called the esophagus device, which is made by Endogastric Solutions. That being said, that's more a reflection on what's currently available in terms of devices and what has evidence in terms of the procedures that we can offer for GERD. I don't have any sponsorship, and this is not an industry sponsored talk, and I have no financial relationship with Endogastric Solutions. So tonight I'd like to first review the rationale for endoscopic therapy for GERD, discuss the technique of endoscopic fundoplasty. I'll talk about some clinical data supporting transoral incisionless fundoplication as a specific procedure. And then we'd also like to talk about the benefits and role of combination surgical and endoscopic intervention, which we have really expanded here at IES. So the currently available endoscopic treatment options include endoscopic fundoplasty, but also radiofrequency ablation with the Stretta device that Dr. Binmoeller mentioned. In addition, there are various procedures that at least have short-term data presented in small case series that essentially involve resection or manipulation of tissue at the gastric cardia and distal esophagus in order to induce scarring, to tighten the GE junction and form an enhanced barrier against acid reflux. These include anti-reflux mucosectomy, where essentially in this picture, the procedure is depicted, essentially resecting tissue to induce scar formation. Resection and plication is the same thing, but added to the resection is endoscopic suturing. And then finally, there's a procedure called clip band ligation anti-reflux therapy. So what I'm going to focus on tonight, and what we primarily focus on in our practice, is specifically endoscopic fundoplication, or more accurately, endoscopic fundoplasty. Really, this is because this is the procedure that has long-term data showing benefit and safety. And there are well-defined anatomic and patient clinical criteria to guide who this procedure should be performed on. So first, what is the rationale for endoscopic therapy of GERD? We know that in some mild cases, patients actually benefit from just lifestyle changes. Really, in the literature, the only lifestyle changes that have evidence behind them, though, are weight loss, or in patients that smoke, smoking cessation. Beyond that, many patients are on PPIs, and many patients have good relief or good control of their acid reflux with PPIs. That being said, actually up to about 40% of patients remain symptomatic on PPI therapy, and this is on standard, full doses of PPIs. This can be for a variety of reasons, including basically inefficacy of treatment, poor adherence, also persistent symptomatology that may be related to non-acid reflux. For this patient population, though, despite uncontrolled GERD symptoms, the sort of conventional intervention or therapy, which is anti-reflux surgery with a Nissen fundoplication, is rarely pursued. And this is for a variety of reasons. Some of it is just fear of an invasive procedure, but the reluctance to pursue surgery or refer for surgery actually exists despite this AGA position statement, which essentially says that surgery should be considered in any patient who is intolerant to PPIs or has persistent troublesome symptoms while on an appropriate dose of a PPI. Some, I think, of the reluctance to pursue surgery is based upon the fact that overall remission rates are very similar between PPIs and anti-reflux surgery in the long run. So I think one of the key components of evidence for anti-reflux surgery, specifically the Nissen fundoplication, is this 2011 RCT called the Lotus trial that compared anti-reflux surgery and PPIs. Again, this showed similar remission rates at 5-year follow-up. The surgery group did have less acid regurgitation, although in fact there was no difference in reported heartburn between these groups. And I think as we've experienced all in our GI clinics, there are certainly long-term structural side effects that happen with anti-reflux surgery, and these sort of symptoms of dysphagia, bloating, flatulence are increased following surgery compared to PPI in this controlled trial. Furthermore, there's about a 30% failure rate following Nissen fundoplication out of 10 years. So I think there's a fair amount of deterrence basically against anti-reflux surgery, apart from patient fear of an invasive procedure. To touch again on the long-term side effects, we see these happen at fairly high rates. So gas bloat syndrome in particular happens in 1/4 to 40% of patients. Patients complain of decreased belching ability, inability to vomit, increased flatulence, and dysphagia. And I think really from the non-surgical side of things, and seeing these patients in GI clinic, we're heavily biased against surgery because these can be very refractory and difficult patients to help. For example, with gas bloat syndrome, apart from potentially trying some methicone or trialing sebotherapy, there's not much to do beyond basically an invasive surgery for a fundoplication takedown. So between the population basically of controlled reflux on PPIs and those who actually pursue surgery, we have this large unmet clinical need. And this is really the kind of treatment gap that exists for which endoscopic therapy potentially provides a solution. The goal of any kind of anatomic intervention for reflux should be correction of underlying deficiencies or distortions in the anatomy that are promoting reflux. There are really 5 main barriers that act as basically impediments to reflux or controls against reflux. And when these start to break down, reflux becomes pathologic. So these barriers are things that we hope to restore with any potential invasive procedure. The barrier functions can be basically attributable to intrinsic LES pressure. So we know there's increased transient relaxation of this pressure, low tonic pressure in pathologic reflux. There's also essentially an external sphincter, which is created by extrinsic compression of the LES by the diaphragm. The intra-abdominal location of the LES is important. Integrity of phrenoesophageal membranes is important, and then the angle of His is important. So when you have basically breakdown of these phrenoesophageal membranes, a hernia starts to develop, and as the diaphragmatic hiatus widens, you have more stomach that can herniate up into the thoracic cavity. With this, you have negative pressure environment basically acting to further relax or stretch open the LES to promote reflux. And then there's also pooling of secretions within the hiatal hernia that promote reflux. So the goals, and now I'm switching, from speaking more broadly about endoscopic fundoplasty to the specific procedure that's available right now called transoral incisionless fundoplication. But the goals of this procedure are hernia reduction, elongation of the intra-abdominal esophagus, and then fundoplication, or manipulation, more specifically, of the gastric cardia to try to create a valve structure where the esophagus basically is plicated against the stomach, and the stomach is tightened around the distal esophagus. This valve-like structure, in theory, will reconstruct the dynamics of the angle of His and restore a distal high pressure zone. What's not accomplished by this TIP procedure is actual repair of the diaphragmatic defect, which still requires surgical intervention. So just a diagram here to kind of go through the procedure for those of you that haven't seen it. This is a device, basically diagram here at the top. And the major components are essentially a helical retractor, which is used to grasp tissue. And then the tissue is retracted down in between the tissue mold and the chassis for manipulation. There are fasteners that are fired to oppose the esophageal and gastric walls. And then there's a tissue invaginator, which is used to, with suction, grasp the esophagus so that the esophagus can be pushed down into an intra-abdominal location. Here in this first picture, you can see this is the device inserted into the stomach, and then the tissue mold is clamped against the chassis here. The scope actually comes down through the device and is put into retroflexion, so you can see the area of the GE junction that's being worked on. During the procedure, and this is done basically in series a number of times, but the first step is grasping the tissue right at the GE junction with the helical retractor. The tissue is then retracted down in between the tissue mold and the tissue chassis. This is clamped down, and then the tissue can be manipulated with torsion added or torque added in order to make somewhat of a wrap. Then this tissue, once it's in the right position, is fully clamped and fasteners are fired. In total, we typically will place at least 20 sets of fasteners. And the end goal is to recreate a valve structure. So this is sort of a nipple valve here, but the general characteristics that we're aiming for are a wrap of 270 degrees and a length of esophagus, a length of the valve of 3 centimeters. So here, this is a movie clip that will be short. This is from actually a combination surgical hernia repair followed by endoscopic fundoplication that we performed here at IES. Here you can see I'm actually grasping tissue right along the GE junction, so you can see the pink squamous tissue of the esophagus. Once the helical screw is in place within the tissue, is used to retract the tissue down. We're pulling this in between the tissue mold and the chassis. And then with suctioning, that adds to the retraction. And now I'm torquing to help make the wrap. Once I have everything in a good position, then the clamp is tightened. You actually turn on the tissue invaginator, and then you're advancing the scope and device so it pulls everything down below the diaphragm so you do not fire your fasteners into any thoracic structures. Once we reinflate, which helps keep other structures out of the way, basically the fasteners are fired. So this is repeated. This is right towards the end of the procedure. I'm just gonna fast forward a little bit. So I have a second set of fasteners being fired right now. And then you can see I'm actually unscrewing the helical retractor. After that, the tissue clamp is loosened. And then you'll be able to advance the device and scope away from this to see the overall structure. So again, we're looking for about a 270-degree wrap, which is present here. Ideally 3 centimeter length on the valve structure. That length is a little bit tougher to achieve in these combination procedures, since there's already been hernia reduction and repair of the diaphragmatic crura done. Okay, so here's just an example of the GE junction, both pre and post procedure. And this is the valve structure over here at 4 weeks on the right. Here's another example of how this looks pre-TIF, post-TIF, and then this is actually an example of what the valve structure looks like at 5 years. So you can see that there are still some fasteners in place. Many times these fasteners do fall out over time, but we're really relying on the fasteners up front to maintain integrity of the structure. After that, what's been shown in animal models is there's actually serosal fusion after apposition of the gastric and esophageal wall to maintain the structure. So now I'd just like to talk about the evidence behind TIF. Really, I think the primary key piece of evidence that's available in the literature is this TEMPO trial. So this is a trial that compared PPI versus TIF in patients with chronic GERD symptoms refractory to PPI. This had a multi-center open label design with option for crossover from PPI to TIF therapy after 6 months. So patients in this trial had persistent daily symptoms, specifically of troublesome acid regurgitation or extraesophageal GERD symptoms. This is despite daily PPI use for over 6 months. Objectively, they had abnormal esophageal acid exposure time on pH monitoring after PPI discontinuation for a week. Patients, as part of the inclusion criteria, oops, I lost my lights here, had abnormal esophageal acid, as part of the inclusion criteria, had absent or small hiatal hernia in a Hill grade 1 or 2. The Hill grade is basically a scoring system based upon endoscopic appearance of the GE junction and how lax it is around the scope when the scope is in retroflexion. Patients had BMIs less than 35, no severe esophagitis, and no long segment Barrett's. The primary endpoint in this trial was elimination of daily troublesome GERD symptoms. Specifically, they do actually specify that this is other than heartburn. Part of the reason for that, I think, is related to the outcomes available in the literature for anti-reflux surgery, in which they were looking at in which the improvement was seen specifically in acid regurgitation and not heartburn. Secondary endpoints in this trial were normalization of pH levels, healing of esophagitis, and complete discontinuation of PPIs. So at 6 months, the elimination of regurgitation was seen in nearly all patients who had received TIF, and only half of patients who continued on PPI. Elimination of all daily troublesome symptoms was also significantly improved or enhanced in patients undergoing TIF. What was not different was normalization of acid exposure in the esophagus. But despite acid levels being the same in the two groups, there was ongoing complete dissatisfaction in the PPI group versus only 11% dissatisfaction reported in the TIF group. Here are some other outcomes that were reported in this trial. This is at 6 month follow-up again. But you can see on the top here in the blue, this is patients who had elimination of atypical symptoms, including hoarseness, throat clearing, cough, globus sensation. This group in the blue is patients who had the TIF and were off PPIs. And you can see pretty significant reductions in these atypical symptoms versus poor response to ongoing PPI therapy for most symptoms. PPI use, again, was in all patients at a daily rate at the time of enrollment. 90% of patients at 6 months after TIF were not taking any PPIs. There was also healing of a reduction of esophagitis in 90% of patients following TIF and only 40% of patients on PPIs. And then elimination of heartburn was seen in 90% of patients after TIF off PPI versus about 10% who had continued PPIs. Patient satisfaction was also significantly higher in the TIF group. So at 6-month follow-up, about 95% reporting having a neutral attitude or satisfied attitude regarding their current health. At 6 months on the PPI group, 70% remained dissatisfied with their current health. So that was all 6-month data. There's now been 3- and 5-year follow-up data published from this template trial. And you can see here in this graph that basically symptom scores that were significantly reduced at 6 months and a year remained low at 5-year follow-up. So just specific outcomes to note at 5 years showing durability were elimination of troublesome acid regurgitation. 86% of people still reported elimination of acid regurgitation at 5 years. 80% continued to report elimination of all atypical symptoms, and the GERD health-related quality of life score remained significantly improved. Looking at PPI use at 5 years, again, 100% were on PPIs daily at study onset. Only 34% required a daily PPI after 5 years. 20% were taking PPI occasionally, but still about 50% had complete cessation at this time frame. About 5% of patients did go on to receive reoperation, or in this case, laparoscopic Nissen fundoplication. This is comparable to rates of reoperation reported following laparoscopic Nissen fundoplication itself. So there are some major caveats with this trial. The first is that it is industry sponsored. This was published, the primary investigator was Dr. Trad, but the funding was provided by Endogastric Solutions, and I think there was collaboration in the trial design as well. So also note, this is a crossover design trial where patients had the option to switch from the PPI arm to receiving TIF after 6 months. And in fact, everybody that was in the PPI group that had continued follow-up at 6 months chose to pursue the TIF. So really we have a trial comparing 2 different groups with 6-month data. Everything after that is sort of prospective observational series. So that trial is specifically in patients that were refractory to PPI use, and that's a little bit discordant with what we think about in terms of patients that are good candidates for surgical intervention, and that those that are best are most likely to respond to Nissen fundoplication are also those that have good response to PPI therapy. Just to address this patient population, there was a study published in 2017 that involved 50 patients followed for about 5 years, who were PPI responsive up front. In this patient population, we also see significant improvement in GERD-related quality of life. And the main acid reflux-related symptom that had been reported up front was abolished in about 75% of patients without the need for any PPI. There's also a trial showing response in PPI responsive patients. So this is a trial published in 2015 in which patients were enrolled that had chronic GERD controlled with PPI but opted for intervention. Primary and secondary outcomes were GERD quality of life, and then secondary was a significant increase in LES pressure, and these were significantly improved with TIF. PPI use was also reported as basically not being necessary at all at 80% of patients at 6 months, but actually at a year, 40% of patients were again taking daily PPI in this group. More recently, there's been a meta-analysis published by Lauren Gerson. This was a meta-analysis of 3 trials that compared TIF to either PPI therapy or sham therapy with at least 3-year follow-up. Up to 3-year follow-up. In this meta-analysis, the sort of outcomes that we've discussed previously are reflected in that TIF resulted in significant improvement in esophageal acid levels, decreased PPI usage, and improved quality of life. So this is a slide, this actually does reflect a compilation that was done of the data in the literature by EGS or Endogastric Solutions, but across many different studies, and some of these are the RCTs we discussed, some of them are prospective observational studies. We see different outcomes that are achieved at about a rate of 80%. So the weighted incidence across 11 studies looking at the percent of patients that were off daily PPIs showed that 80% of patients achieved this outcome. 80% of patients also had healing of esophagitis across studies where there was at least 3-year follow-up. Quality of life was improved in about 80% of patients with at least 6-month follow-up. And then patient satisfaction, specifically in patients with follow-up greater than 59 months, was also achieved in about 80%. There is now 10-year data available regarding the outcome of TIF. This specifically is a study published out of Europe that involved 50 patients, all with pathologic reflux and positive symptom correlation at the study onset. So similar to the data published following the TEMPO trial at 5 years, we can see here that there's good durability in symptom reduction that lasts for 10 years out. In addition, this study reported at 10 years that about 90% of patients were able to still have reduction in dosage of their PPI. In fact, the dose was either halved or stopped. But one important caveat here is that there's actually only about 25% patient follow-up at this time frame, so a lot of potential dropout bias existing here. Overall, TIF has been shown to be very safe. So this is based upon the MOD database, or sort of aftermarket reporting by manufacturers and users of devices. Overall, there have been 22,000 commercial cases of TIF performed with a serious adverse event rate of about 0.4%. These complications do include perforation, injury to the lining of the esophagus and stomach, or actually the oropharynx as well, bleeding, esophageal or gastric leak, and the complications of infection related to that, and then pneumothorax, pneumomediastinum, and pneumoperitoneum reported as well. So now just to comment on the contrast basically of TIF and surgery. There hasn't been any direct comparison published of TIF and surgery. And really, the TIF is a procedure not necessarily designed to replace surgery. That being said, I think since many patients don't pursue surgery, it's, I think, appropriate to look at the differences in outcomes between endoscopic and surgical therapy, since endoscopic therapy ends up being sort of the end therapy for patients often. A systematic review was published by Joel Richter and a group of surgeons in 2018. This looked at 7 RCTs that compared TIF or laparoscopic Nissen fundoplication to either sham or PPI therapy. What this meta-analysis found was that, sort of, I think, as expected, surgical fundoplication achieves better objective acid measures in the esophagus and better LES pressures or better LES parameters. However, TIF was actually found to result in higher improvement in GERD-related quality of life. So again, there's no direct comparison regarding these two treatment modalities, but what's published in the literature offers quite a contrast in terms of the rate of long-term side effects. So we discussed dysphagia, gas, bloat, and flatulence occurring after anti-reflux surgery. The rates of these occurring after TIF are actually very low, anywhere from 0 to 6%. When you're considering a patient for a TIF, the main contraindications to ensure are not present are basically factors that may exist that would increase the risk of perforation or tissue injury. So this includes eosinophilic esophagitis and connective tissue disease. This also includes restrictions in neck mobility, as well as the presence of cervical osteophytes. The reason for that is the device itself is actually 20 millimeters in diameter, so it can be fairly difficult and sometimes tedious to actually get the device down. So if you have any issues in the upper esophagus or at the UES or in the oropharynx, that can present a problem and actually increase risk of perforation. Other contraindications include coagulopathies or things that may increase risk of bleeding. Morbid obesity, we know that with surgical fundoplication, the outcomes are poorer, basically in obese patients. And really with a BMI over 35, the anti-reflux procedure that should be considered is essentially a gastric bypass. And then motility disorders are also a contraindication, since anything done to tighten the LES will potentially exacerbate symptoms or problems. Anatomically, patients that undergo TIF should have basically certain features, and this is really based upon earlier studies with earlier generations of TIF that show poor outcomes based upon certain anatomic criteria. Specifically, if any hiatal hernia is present, it should be smaller than 2 centimeters. The Hill grade should be low, and then clinically, patients should have daily bothersome GERD symptoms and some measure proving GERD, whether there's objective evidence on endoscopy with esophagitis or Barrett's, or positive or abnormal pH monitoring or an esophagram. So actually, based upon these selection criteria, we find that the significant majority of patients that are referred for anti-reflux intervention here at IES actually are not candidates for TIF alone. So what we've focused on in these patients, and I think what is starting to be justified in the literature, is actually combination therapy involving laparoscopic hiatal hernia repair with hernia reduction and basically repair of the diaphragmatic hiatus with crural closure or tightening, followed then by endoscopic fundoplasty. The goal of this combination therapy is to achieve the durability and efficacy of a surgical hernia repair while achieving the long-term side effect profile of endoscopic fundoplasty. There's been a series recently published involving 100 patients that underwent this combination procedure. These patients had a hiatal hernia ranging from 2 to 5 centimeters in size, moderate to severe symptoms lasting for at least a year. These patients did have at least partial response to PPIs over 6 months, then also had objective evidence of GERD. So with this combination procedure, at 12 months, there was significant reduction in a variety of symptom scores, improved satisfaction with current health, and then reduction in PPI usage. This is just basically a chart representing response to various symptom questions, but we see that there's reduction in symptom scores, basically compared to baseline at 6 months and 12 months for a variety of symptoms. And then this study also showed, again, decreased need for PPI usage. So at baseline, about 90% of patients were either taking daily or twice daily PPIs. Following this combination intervention, at 12 months, 70% of patients never needed a PPI. No laparoscopic or endoscopic complications were reported with this procedure in this series. And very importantly, with the endoscopic fundoplication, rather than the full Nissen, no increased rates of gas bloat, inability to belch or vomit were reported. So in addition to this initial series, there's been a second series published that shows, again, significant reduction in symptom scores, but also significant improvement in pH levels within the esophagus. On follow-up, and the mean follow-up was about a year in this series, patients who had an intact hiatal hernia repair and an intact TIF had almost universal normalization of acid levels. Here is just an example, basically, from a patient that we did here at IES, where we see the pre-procedure anatomy and then what things look like afterwards. And this is after, basically, the combination procedure, so both laparoscopic hiatal hernia repair and endoscopic fundoplasty. On the left here, you see this patient has Hill grade 4 anatomy with obvious hiatal hernia, persistent opening around the scope. And it's quite easy to see the squamous tissue of the esophagus. And here you have restoration or recreation of a valve-like structure and Hill grade 1 anatomy. So there are a couple other populations where we consider TIF. One is in patients who have had failed Nissen. So we know that the morbidity and mortality associated with laparoscopic Nissen fundoplication is significantly increased during any redo fundoplication. And in fact, the intraoperative complication rate is about 10 to 20%. This can be a difficult procedure, even in the hands of an experienced surgeon. So as an alternative, if the anatomy is correct, TIF is available, and this has been addressed in at least a small case series. So this wouldn't apply if the patient actually has a slipped Nissen or a large recurrent hiatal hernia, but if the issue is just loosening of the wrap, then TIF with the basically plicating fasteners can sort of retighten the wrap. The series that's available involved a small number of patients who had a loosened wrap and abnormal pH study or other objective evidence of GERD. These patients at a little over a year follow-up had normalization of acid levels and improved GERD after a TIF revision of their failed Nissen. So just like laparoscopic Nissen fundoplication, unfortunately, we know that over time, the efficacy of TIF can wear off, and while symptoms are durable, certainly there's a return to PPI use in a significant number of patients and potentially recurrence of symptoms. In these patients, there are 3 series, actually, 2 of them are listed here, that have shown that if necessary, laparoscopic Nissen is safe and feasible. Where I think the jury is out, but what we are actively looking into is there a benefit to essentially repeat TIF? So you have most of the structure in place still. Can you just go in and add some fasteners to essentially retighten things and restore the initial symptom response that was achieved? Finally, I think this is always a concern for referring providers, but one thing that can be a barrier to any kind of endoscopic intervention, in particular newer endoscopic intervention, is insurance coverage. So for the TIF procedure, there has been a CPT code in place since 2016. Universally with Medicare, there are no issues in having coverage for this procedure. We do know, though, that other insurance providers in California still may deem this procedure experimental, despite what really is level 1 evidence that's available now. What we have found, though, is for the concomitant procedure, the combination surgical and endoscopic procedure, there are really no issues with coverage whatsoever. So in conclusion, endoscopic fundoplasty fills a treatment gap between PPIs and surgery, and it achieves a reduction in symptom scores and some improvement in pH levels. And TIF is effective and safe with appropriate patient selection. The issue, however, is that most patients do not have proper anatomy for TIF alone. In these patients, hybrid surgical and endoscopic intervention achieves subjective and objective improvement while avoiding the long-term adverse effects of Nissen fundoplication. And while we didn't discuss them, other endoscopic options are certainly possible, in particular the ARM or the resection and plication. These procedures may be useful in particular in patients with altered anatomy where the stomach is restricted and too restricted actually to even use the TIF device. That being said, the data is limited for these other procedures. Okay, so thank you everyone for sticking with us. At this point, you can take some questions. Dr. Binmoeller, I'm going to unmute you.
Good. All right, you can probably hear me now. So excellent. Thank you, Andrew. So we've got some time for discussion now. And I just want to emphasize why this topic of endotherapy of GERD is something not just important. I feel that our role as endoscopists is so critical as endoscopists and gastroenterologists, because it's not just about quality of life for these patients, if it was just about the heartburn, the inconvenience of heartburn, then I would say no question, PPIs are wonderful, and whatever relieves the heartburn is fine. But it's not about that quality of life. For me, it's about the complications of GERD, and what we're seeing on epidemic proportions now is Barrett's, and of course, as you know, esophageal cancer, adenocarcinoma. It's growing just exponentially. It's the most rapidly growing cancer in the West, and I think now the East is following suit with that as Western diet becomes more pervasive in Asia. But it's also about the side effects, the complications of the PPIs. So now that we have a better understanding of PPIs, that these are not as innocuous as we thought when given long term, we're all aware of all the different potential long-term side effects. And of course, dementia is something that always concerns the patient. I can't tell you how many patients come to me and they're worried about that. They're worried about Alzheimer's, but now they're worried about their PPI contributing to that risk. And of course, cardiovascular and renal, and it all started with the hip fracture issue, but now that list is growing and growing. So really now for me, the game has changed completely. Before, back in 2001, it was really about PPIs versus endotherapy. Now this has changed completely. It's really about endotherapy versus surgery, because these are patients where we really need to address the underlying cause of GERD. And it's a mechanical problem. It's not about acid suppression here. It's not a hyper secretion of acid problem. So it's not just about the symptoms. So I just want the audience to understand why we have very strong, we're very invested in seeing this area develop. And the type of study I'd like to see is a randomized controlled trial comparing endotherapy with what otherwise has been the mainstay for refractory GERD, which is surgery, the Nissen fundoplication. So let's start with the first question, Andrew. That is, what about the need for esophageal manometry prior to consideration of TIF? I think this is a great question. It is the standard, I think, for surgeons. And I don't think you want to have a Nissen fundoplication and afterwards have dysphagia because you had a motility disorder. What are your feelings about manometry before TIF, though?
Yeah, I mean, certainly I think that can present a big problem. And certainly at IS, we've seen, a number of patients with severe dysphagia after Nissen fundoplication that didn't necessarily have manometry or proper interpretation of manometry before the surgery. And then post-procedure, you're left with a picture that is tough to distinguish between true achalasia or basically a wrap that's too tight. In general, the sort of rule that we follow with the TIF, though, since there is what's less basically constriction due to the fundoplication that's created versus the surgery, and since there's significantly less dysphagia that actually occurs after the procedure, the rule that we follow is basically if they're symptomatic, then we ensure the manometry is performed to rule out any motility disorder. Or if there are findings concerning on endoscopy or esophagram. That being said, I think if patients are completely asymptomatic, and this does actually follow the practice of surgeons also prior to Nissen fundoplication, we don't necessarily pursue manometry. A lot of patients actually end up getting manometry, however, as part of their pH impedance testing.
Yeah, and would you also mandate impedance plus minus 24-hour pH in all patients undergoing TIF?
Yeah, so if there are atypical symptoms or anything that doesn't clearly sound like acid reflux, then I think it's important to get pH impedance testing to ensure pathologic reflux, but also just as importantly, ensure symptom correlation, so that we can actually have some reasonable expectation that TIF is going to improve these symptoms. Specifically, I think the scenario where I don't necessarily get pH impedance testing beforehand are patients who have classic heartburn symptoms responsive to a PPI, and some objective evidence of reflux on endoscopy, primarily either esophagitis or Barrett's esophagus.
Okay, we have another question here about the LINX procedure. What are your thoughts of LINX versus TIF? And of course, that's sort of a hybrid procedure, right? Because they're always addressing the hiatal hernia, right? They're doing a hiatal hernia repair laparoscopically, but since the surgeon's already in there, then they place the magnet. So it's also a hybrid procedure.
Yeah, I think that I don't think that there's been a direct comparison in the literature, in terms of counseling patients, because many patients ask about the magnetic sphincter augmentation as an alternative to TIF. If we're talking about the LINX alone, so without hernia repair, the patient population tends to be, about the same. So you're looking for a patient with anatomy that's not that distorted. Certainly, we're biased from the interventional endoscopy perspective, in that I think that among this patient population, TIF is a good alternative that doesn't require surgery, and more particular to interventional endoscopy, where often I think the personnel that's dealing basically with erosion of the magnetic ring. So that can, of course, require reoperation, but oftentimes we're seeing these patients who are having severe symptoms as the magnet starts to erode through the tissue.
So I just feel really strongly here that any patient with a significant hiatal hernia, so that would be defined as, greater than 2 centimeters, but it's a gestalt thing when you're doing endoscopy. And when a patient has a significant hiatal hernia, and I think those patients absolutely have to undergo a hernia repair procedure. Does it have to be done together with TIF if you want to take a hybrid approach, or could you just repair the hernia and then have the patient undergo TIF at a later time?
Yeah, I think that is feasible, certainly, patients are at different sites, having a hernia repair done and then doing endoscopic fundoplication after that. I will say that I think you're hard pressed to have that set up though with the surgeon, since if anti-reflux intervention with the TIF is not being done at the same time, I think that they typically, because I've had patients ask to have this done before as a staged procedure, but typically the surgeon will say, well, in that case, I'm gonna go ahead and do fundoplication during the surgery rather than having two separate procedures.
Okay. What about dysphagia after TIF? Did you see that? And if the patient develops dysphagia, how do you treat it? Is it reversible?
Yeah, so this is reported in very low rates in the literature. Again, the rate of dysphagia after TIF is 0 to 1%. Personally, I've had one patient that had some dysphagia after TIF. I think the first thing to really exclude is essentially persistent pathologic acid reflux, since we know that's a very common cause of ineffective esophageal motility and the correlate symptom of dysphagia. I think that the evaluation basically includes esophageal manometry and potentially endoflip, which is impedance splenimetry, looking at the distensibility of the GE junction after TIF. And in the case where we actually had a complaint of dysphagia afterwards, both of those studies were actually normal, and sort of empiric dilation was done. So I think it would be, the interventions essentially would be dilation, and perhaps even pneumatic dilation with recognition that this is going to likely cause breakdown of the valve structure created with these plicating devices. But that would be sort of the pathway necessary if you actually had pathology at the LES going along with the dysphagia.
Yeah, so at least for the TIF procedure, The beauty here is that the scope itself, since you're in the stomach and retroflexion, so the scope itself limits how tight you will constrict the GE junction. Now that's different from, for example, that arm procedure with the mucosectomy and basically creating scarification. There, I'm more concerned about strictures forming afterwards. What are your thoughts about that? Because that, of course, has received a lot of press. Something any of us could do, right? Do mucosectomy at the GE junction and then circumferential. And we know from EMR and ESD that you'll get a stricture.
Yeah, so in the study that's been reported regarding anti-reflux mucosectomy, but actually this applies to the study reported on resection and plication as well. The rate of dysphagia after these procedures due to excessive stricturing is 10%. This is something, since it's just scar tissue, that can typically be dealt with endoscopic dilation. Although when this option has been presented to patients, again, as an alternative to TIF, the thought or potential for multiple follow-up endoscopies to dilate a stricture is typically enough of a deterrent that they don't want to hear anything more about this procedure, in particular in light of the short-term data that's available for these procedures.
What about Barrett's esophagus, Andrew? If a patient has Barrett's, non-dysplastic, do you treat that before you do the TIF, plus minus the surgical hernia repair, or after? Or not at all? Leave the Barrett's alone. Do you think it will reverse after you repair the hernia and do the TIF?
Yeah, so for non-dysplastic Barrett's, in the absence of any other risk factor, in particular, first-degree relative with esophageal cancer, I leave it alone. Certainly, there's not evidence to suggest that regression will happen after TIF, and in fact, we know even for Nissen fundoplication as the sort of gold standard, there's no evidence, although there's a trend in the literature, there's no evidence that actually esophageal cancer rates are reduced following Nissen. So, there's not data supporting this, but we all know that on PPI, sometimes you see basically regression of Barrett's without intervention or treatment of the Barrett's. So if it's non-dysplastic, I think there's perhaps a chance, although I don't expect it, that the Barrett's will regress following TIF. But I still won't do any kind of ablation therapy unless we're having dysplasia.
But if it's Barrett's with low-grade dysplasia, that you would treat, right?
That I would treat. Part of that is I think in general, and sort of the standard now is to treat low-grade dysplasia. Part of treating before the procedure also relates to the fact that many of our procedures are the hybrid procedures, and I think that there is more concern about endoscopy shortly after the Nissen fundoplication, in terms of the ability to disrupt the surgical sutures. So I just get the treatment out of the way for the Barrett's.
So, Andrew, when the patient comes to you and asks about their PPI that they've been on for a few decades already, and they've been reading about all these associations, but for them, they think that these PPIs are causing dementia, stroke, heart attacks, chronic renal failure, C. difficile colitis, the list goes on. What do you tell them?
The basic message I give for these associations with PPIs are that there's certainly reports out there, and there are things that we have to be aware of, but I think the level of evidence, it should not be the sole factor for pursuing invasive intervention. In particular, some of the I guess the main motivation should still be basically improvement of quality of life. So I do have a reference side for that, because in other talks that often will come up in terms of the evidence behind these PPIs and associated side effects. But we know that they're essentially retrospective sort of cohort studies that report this association. and the sort of odds ratios are all relatively low for most of these associations. But these are potential things in the literature and things that we shouldn't completely ignore. So I think the rule should be, whenever possible, the dose should be as low and as infrequent as necessary for symptom control. And certainly, if there is motivation to stop PPIs, that this can add basically to the factor for seeking endoscopic intervention. I think part of the difficulty with being very stringent in terms of recommending endoscopic intervention in order to stop these PPIs is that we know that a significant portion of patients end up back on some type of PPI therapy. So right now, with what we have in terms of what's available for endoscopic intervention, it's tough to justify the intervention by the possibility of PPI avoidance alone.
Great. Well, it's 6 o'clock, so we're into our hour, and I'd like to thank everyone in cyberspace for joining us this afternoon here in San Francisco on the West Coast. It's the early evening in other parts of the US. And I hope you enjoyed this. Please give us feedback how we can make these webinars, which we will continue, better and hopefully more interactive. So we look forward to future interactions. So with that, have a great evening and see you next time. Thank you.
Thank you, everyone.